Welcome to How to Initiate Rapid-Acting Insulin in the Primary Care Setting. I'm Robert Bush of the Endocrine Group in Albany, New York. The objectives for this program are to discuss the over-reliance on basal insulin among some patients being treated for type 2 diabetes mellitus and review the benefits of intensifying insulin therapy with a rapid-acting insulin, to highlight clinical data supporting insulin intensification with a rapid-acting insulin, and to discuss how to initiate and titrate rapid-acting insulin using a sample case. The first slide presents a recent analysis of data from the National Health and Nutrition Examination Survey, which looked at trends in glycemic control in the United States in adults greater than or equal to 18 years of age who reported a previous diagnosis of diabetes and received an A1C measurement. As depicted on the right side of this graph, improvements in glycemic control have certainly occurred over time, but it's clear that many patients still have an A1C level above 7%. In fact, approximately 43% of treated patients with type 1 and type 2 diabetes do not meet the goal of reaching an A1C under 7% set by the American Diabetes Association. The ADA and the European Association for the Study of Diabetes recently published a joint update to their position statements on treatment of type 2 diabetes, and in it addressed the various treatment options and their different effects on efficacy and safety. The guidelines suggest the glucose-lowering effectiveness of non-insulin pharmacological agents is high for metformin, sulfonylurea, TZDs, and GLP-1 agonists with an expected A1C reduction of approximately 1% to 1.5%. DPP-4 inhibitors have an intermediate glucose-lowering effect as they reduce A1C approximately 0.5 to 1%. Insulin is associated with the greatest expected decrease in A1C. However, high doses of basal insulin may not provide control of postprandial glucose and may also increase the risk for hypoglycemia. So how do you know if a patient is receiving too high a dose of basal insulin? A good rule of thumb is this. When the titration of basal insulin achieves a fasting blood glucose level between 80 and 100 milligrams per deciliter, and the patient is still not at A1C goal, a more intensive therapy may need to be initiated to help control the postprandial glucose. If glycemic control has not been achieved, including control of postprandial glucose, then the patient may require the addition of prandial insulin to an appropriate basal insulin regimen. The graph shows the contribution of fasting plasma glucose and postprandial glucose to overall hyperglycemia in patients with different A1C levels. Among patients with the highest A1C levels, fasting plasma glucose accounted for about 70% of hyperglycemia. As A1C improves, the relative contribution of fasting plasma glucose declines and the relative contribution of postprandial glucose increases. Although the patients in this study were not receiving insulin, we expect a similar change when patients initiate basal insulin. As the basal insulin therapy leads to improvements in fasting plasma glucose and declines in A1C levels, we should expect that postprandial glucose makes a greater contribution to the remaining hyperglycemia. To achieve further improvements in overall glycemic control without increasing the risk of hypoglycemia, we will need to address the problem of postprandial glucose excursions. In this hypothetical diagram, blood glucose levels during a typical day are represented by the yellow curve. In a patient receiving high doses of basal insulin, fasting plasma glucose levels may be within recommended ranges, but postprandial excursions continue to exceed recommended levels. Such patients are also at increased risk for hypoglycemic episodes if their diet changes or they miss a meal because of continuously high insulin levels. The American Diabetes Association and the European Association for the Study of Diabetes recently published an update to their position statement on the medical management of hyperglycemia in type 2 diabetes. This update shifted towards a more individualized, patient-centered approach compared with the more algorithmic, prescriptive approach of the 2009 guidelines. This ensures that treatment decisions will be adapted to each patient's specific needs, which will engage the patient and may enhance adherence to therapy. Because of the increased risk of type 2 diabetes due to a sedentary lifestyle and overeating, lifestyle modification is recommended for all patients. Metformin is recommended for initial treatment at diagnosis along with lifestyle intervention. If glycemic goals are not achieved by about 3 months, one of 5 treatment options in combination with metformin should be considered. Basal insulin has excellent efficacy, but put patients at high risk of hypoglycemia. Sulfonylurea and thiazolidinedione demonstrate high efficacy, but come with a considerable risk of hypoglycemia and edema, respectively. DPP-4 inhibitors are considered very safe with low risk of hypoglycemia, but with intermediate efficacy. GLP-1 receptor agonists have high efficacy and low risk for hypoglycemia, but are associated with gastrointestinal side effects. In cases where the patient is intolerant of metformin or if metformin is contraindicated, initial treatment should be selected from other classes of drugs with consideration of 3 drug combinations. Although patients may eventually require complex insulin strategies, basal insulin should be attempted first. In patients with severe hyperglycemia from onset, a more rapid progression from 2 drug combinations to complex insulin is an option. In type 2 diabetes patients, the preferred initial insulin treatment regimen is basal insulin, usually in combination with 1 or 2 non-insulin therapies. Patients with high A1C levels should consider a more advanced treatment, either with a basal plus mealtime insulin or a premixed insulin twice daily. Patients should proceed to basal plus mealtime insulin if basal insulin has been titrated to an acceptable fasting glucose but A1C goals are not being met. It's also possible to progress from basal insulin to twice daily premixed insulin, although this approach is not well studied. Therapy should be individualized, and when a treatment approach is selected, dose adjustments should be made based on patient-reported glucose levels. Now, let's briefly review the American Association of Clinical Endocrinology algorithm for intensifying insulin therapy for type 2 diabetes as published in the March-April 2013 edition of the journal Endocrine Practice. As shown on the left, start basal, long-acting insulin in patients whose A1C is less than 8% at a total daily dose of 0.1 to 0.2 units per kilogram, and start those whose A1C is greater than 8% with a total daily dose of 0.2 to 0.3 units per kilogram. Then, titrate insulin every 2 to 3 days to achieve glycemic goal. Consider discontinuing or reducing sulfonylurea after basal insulin is started. If glycemic control is not at goal, follow the algorithm on the right side of the slide. The goal here is to achieve prandial control by adding a GLP-1 receptor agonist or DPP-4 inhibitor, or by adding prandial insulin. If the GLP-1 receptor agonist or DPP-4 inhibitor does not achieve glycemic goal, consider further intensification. For patients on prandial insulin, the total daily dose should be 0.3 to 0.5 units per kilogram, consisting of 50% basal analog and 50% prandial analog. Less desirable are NPH and regular or premixed insulin. More detailed information can be found by reviewing the published ACE algorithm. This concludes the disease awareness portion of the presentation. We'll now review the use of specific insulin therapies, beginning with the initiation of basal insulin therapy with Levemir, insulin detamir rDNA origin injection. Levemir is a soluble, long-acting basal human insulin analog with a relatively stable pharmacologic profile with no pronounced peak. Levemir has a duration of action of up to 24 hours, and it is indicated to improve glycemic control in adults and children with diabetes mellitus. Levemir is not recommended for the treatment of diabetic ketoacidosis. Intravenous rapid-acting or short-acting insulin is the preferred treatment for this condition. Also, Levemir is contraindicated in patients with hypersensitivity to Levemir or any of its excipients. Before moving on, let's take a brief moment to review some of the important safety information for Levemir. Monitor blood glucose in all patients treated with insulin. Insulin regimens should be modified cautiously and only under medical supervision. Do not dilute or mix with any other insulin or solution. Do not administer subcutaneously via an insulin pump, intramuscularly or intravenously because severe hypoglycemia can occur. Hypoglycemia is the most common adverse reaction of insulin therapy and may be life-threatening. When a GLP-1 receptor agonist is used in combination with Levemir, the Levemir dose may need to be lowered or more conservatively titrated to minimize the risk of hypoglycemia. Severe, life-threatening generalized allergy, including anaphylaxis, can occur with insulin products, including Levemir. Careful glucose monitoring and dose adjustments of insulin, including Levemir, may be necessary in patients with renal or hepatic impairment. Fluid retention and heart failure can occur with concomitant use of thiazolidinediones, TZDs, which are PPAR gamma agonists, and insulin, including Levemir. Adverse reactions associated with Levemir include hypoglycemia, allergic reactions, injection site reactions, lipodystrophy, rash, pruritus, and if taken with GLP-1 receptor agonists, diarrhea. Needles in Levemir FlexPen should never be shared. Levemir has not been studied in children with type 2 diabetes or in children with type 1 diabetes who are younger than 2 years of age. The background risk of birth defects, pregnancy loss, or other adverse events that exist for all pregnancies is increased in pregnancies complicated by hyperglycemia. Now, when starting treatment with Levemir, there are a few important considerations regarding dosing. In patients with type 2 diabetes, Levemir should be initiated at 10 units or 0.1 to 0.2 units per kilogram once daily in the evening or at bedtime, and then adjusted to achieve glycemic targets. When converting from insulin glargine, convert unit for unit to Levemir. So, how do we intensify insulin therapy in patients needing a rapid-acting prandial insulin? As an example, let's discuss initiation of the rapid-acting insulin Novolog, insulin aspart rDNA origin injection. Novolog is a rapid-acting insulin analog with a faster onset of action and shorter duration of action than regular human insulin. Because of its fast onset of action, Novolog should be given 5 to 10 minutes before a meal. Novolog is indicated to improve glycemic control in patients with type 1 and type 2 diabetes and children over age 2 with type 1 diabetes. Novolog is contraindicated during episodes of hypoglycemia and in patients hypersensitive to Novolog or one of its excipients. Now let's review some important safety information for Novolog. Novolog should be generally given immediately within 5 to 10 minutes prior to the start of a meal. As with all insulin preparations, the time course of action of Novolog may vary in different individuals or at different times in the same individual and is dependent on many conditions including injection site, local blood supply, temperature, and level of physical activity. Novolog should be used with a longer-acting insulin. When used in an external subcutaneous insulin infusion pump, Novolog should not be mixed with any other insulin or diluent. Hypoglycemia is the most common adverse effect of insulin therapy. The timing of hypoglycemia may reflect the time-action profile of the insulin formulation. Glucose monitoring is recommended for all patients with diabetes and is particularly important for patients using external pump infusion therapy. Any change of insulin dose should be made cautiously and only under medical supervision. Insulin, particularly when given intravenously or in settings of poor glycemic control, can cause hypokalemia. Use caution in patients predisposed to hypokalemia. Like all insulins, Novolog requirements may be reduced in patients with renal impairment or hepatic impairment. Severe life-threatening generalized allergy, including anaphylaxis, may occur with insulin products, including Novolog. Fluid retention and heart failure can occur with concomitant use of thiazolidinediones, which are PPAR gamma agonists, and insulin, including Novolog. Adverse reactions observed with Novolog include hypoglycemia, allergic reactions, local injection site reactions, lipodystrophy, rash, and pruritus. Needles in Novolog FlexPen must not be shared. Novolog has not been studied in children with type 2 diabetes or in children with type 1 diabetes who are younger than 2 years of age. The background risk of birth defects, pregnancy loss, or other adverse events that exist for all pregnancies is increased in pregnancies complicated by hyperglycemia. Novolog is designed to closely resemble the body's normal mealtime insulin response. This was demonstrated in a randomized, blinded crossover trial in 22 patients with type 1 diabetes mellitus. In this trial, free serum insulin concentrations were measured for up to 6 hours after each of 2 treatment phases. The broken blue line represents the body's normal insulin response. The gray line represents one treatment phase where regular human insulin was injected 30 minutes before a comparable meal. And the orange line represents the other treatment phase where a single dose of Novolog was injected immediately before a meal, demonstrating that mean serum level of free insulin in patients who received Novolog closely mimicked a theoretical physiologic insulin excursion that would be expected in a non-diabetic person after ingestion of a test meal. Novolog can provide up to 50 to 70% of total daily insulin requirements as part of a basal bolus regimen for type 2 diabetes, with the remainder provided by an intermediate-acting or long-acting insulin. The dosage of Novolog must be individualized and, when given by subcutaneous injection, should generally be used in regimens that include intermediate or long-acting insulin. The total daily insulin requirements may vary and is usually between 0.5 to 1 unit per kilogram per day. So what are the alternative approaches for introducing patients to a rapid-acting insulin analog? Insulin intensification with a rapid-acting insulin analog can be implemented by adding multiple daily injections at once, as demonstrated in the 4T trial, or by adding one injection at a time in a stepwise manner, as demonstrated in the stepwise trial. The area I want to focus on today is the approach taken in the stepwise trial. Now let's review in detail exactly how one study implemented treatment intensification by stepwise addition of Novolog. The stepwise trial enrolled 345 patients who were inadequately controlled on basal insulin and oral antidiabetic agents. A total of 296 were randomized to treatment. 2 approaches for introducing Novolog were studied and found to be comparable. This diagram illustrates an approach that you can use with your patients. Using one of the approaches, following a 12-week run-in period with Levemir and oral antidiabetes drugs, patients initiated Novolog as a single injection of 4 units before the meal they perceived to be the largest meal of the day and titrated as per protocol. After 12 weeks, if A1C was greater than or equal to 7%, a second injection of Novolog, 4 units, was added before the second largest meal. Similarly, at 24 weeks, if A1C was still greater than or equal to 7%, a third injection of Novolog, 4 units, was added before the third largest meal. Throughout the 36-week trial, the Novolog dosage was adjusted on the basis of pre-meal and bedtime plasma glucose levels. Once daily basal insulin was maintained and titrated following the titration protocol throughout the entire study. In this trial, glycemic targets were 72 to 108 milligrams per deciliter for pre-meal plasma glucose and 72 to 144 milligrams per deciliter for bedtime plasma glucose. For patients outside these target ranges, recommended dosage adjustments were -2 units when plasma glucose was under 72 milligrams per deciliter before lunch or dinner or at bedtime, +2 units when it was greater than 109 to 162 milligrams per deciliter before lunch or dinner, or greater than 145 to 180 milligrams per deciliter at bedtime. and plus 4 units when it was greater than 162 milligrams per deciliter before lunch or dinner, or greater than 180 milligrams per deciliter at bedtime. It is worth noting that these adjustments are made in increments of 18 milligrams per deciliter, which is equivalent to 1 millimole per liter. Some countries utilize the Système International unit of millimoles per liter rather than the milligrams per deciliter used in the United States. This information can be particularly helpful for patients who travel overseas. By using this approach for introducing and titrating Novolog, the mean A1C levels declined from 8.6% at screening to 7.5% at 36 weeks. At the end of the study, 77% of patients were using 3 Novolog injections per day. In the group with an 8.7 mean baseline A1C level, 31% achieved the ADA goal of A1C below 7% by the end of the study. Among patients using this stepwise approach of first introducing Novolog at the meal patients perceived to be the largest meal of the day, major hypoglycemic episodes, defined as requiring third-party assistance, occurred at a rate of 0.04 episodes per patient per year. Minor episodes, in which plasma glucose was equal to or fell below 56 milligrams per deciliter, but was managed by the patient, occurred at a rate of about 6 episodes per patient per year. Doses of basal and bolus at baseline and 36 weeks are shown here. At the beginning of the run-in period, the mean daily Levemir dose was 0.4 plus or minus 0.2 units per kilogram in both treatment groups, which increased to 0.6 plus or minus 0.3 units per kilogram at randomization. The mean daily dose of Novolog increased continuously during the trial. At 36 weeks, the basal to bolus dose ratio was 1.4 in the patient-perceived largest meal approach, consisting of 58% basal and 42% bolus. By week 36, 42% of the total daily insulin dosage on average was bolus insulin administered at mealtime, consistent with our earlier discussion in which we noticed that bolus insulin can account for up to 50 to 70% of the total insulin dose in some patients. So, in summary, the stepwise trial showed the feasibility of introducing Novolog by starting with a single dose at the meal perceived by the patient to be the largest meal of the day, and then adding Novolog at other meals as required to achieve glycemic control. With the addition of Novolog, mean A1C levels declined by 1.1% in the patient-perceived largest meal treatment arm. The greatest A1C reductions were achieved after introduction of the first and second bolus injections. The number of hypoglycemic episodes increased with increasing the number of Novolog injections, but the overall rate of hypoglycemic episodes was low. To illustrate the stepwise approach to introducing Novolog, let's examine the case of Joe. Joe has long-standing type 2 diabetes that's poorly controlled on metformin and 50 units per day of basal insulin. Note in particular his high average postprandial glucose level. Some possible modifications to Joe's therapy to improve his A1C include implementing lifestyle modifications including diet and exercise, increasing the dose of Joe's basal insulin, and intensifying with a rapid-acting insulin, such as initiating basal bolus therapy with 1 injection of Novolog, or initiating basal bolus therapy with 3 injections of Novolog. As we review this case, please remember that insulin dosing may vary from patient to patient, and that all dosing and monitoring should be individualized to meet the needs of each patient. According to Joe, his largest meal of the day is usually lunch, and he agrees that lunch would be a convenient time for him to add a prandial injection of insulin. So they agreed to add Novolog injection just before lunch, starting at a dosage of 4 units. Joe understands that once he has done the injection, he cannot delay eating lunch without risking a hypoglycemic episode. Remember that insulin dosing may vary from patient to patient. Therefore, all dosing and monitoring should be individualized to meet the needs of the specific patient. Because Joe added Novolog before lunch, he's instructed to measure and record his blood glucose levels just before dinner, and those values average about 151 during his first week. Using the titration schedule shown previously, it's recommended that his dosage be increased by 2 units, up to 6 units. This process is repeated every 2 weeks until Joe's pre-dinner glucose values are within the target range. During this time, it's also important to continue monitoring his fasting plasma glucose levels and adjusting his basal insulin dosage to avoid hypoglycemic episodes. Over 3 months, Joe's Novolog is titrated up to 18 units. His A1C is decreased from 8.8 to 8.3%. To better achieve his A1C goal under 7%, a second injection of 4 units of Novolog is added to Joe's second largest meal, dinner. After 2 weeks, we review Joe's 4 times daily blood glucose measurements to determine if he needs any adjustments. As a result, lunchtime Novolog is increased by 2 units and dinnertime Novolog is increased by 4 units. Levemir is maintained at 50 units. Joe's final script is shown here. His lunchtime Novolog is increased from 18 to 20 units, and his dinnertime Novolog is increased from 4 to 8 units, while his Levemir remains at 50 units. We'll continue to titrate and treat according to Joe's measured self-monitored blood glucose values. To facilitate administration with patients like Joe, Novolog is available for delivery via a FlexPen. FlexPen is the only pre-filled pen available with basal, bolus, or premixed insulin analogs and is compatible with NovoFine needles. When talking to your patients about FlexPen, it's helpful to mention that needles are sold separately and may require a prescription in some states. I hope this review of Joe's case provided a good illustration of how to introduce the stepwise approach of bolus insulin in a patient poorly controlled on basal insulin plus metformin. In summary, it's important to continue monitoring patients on basal insulin and to be vigilant about not over-relying on basal insulin. As their A1C levels improve after initiating this therapy, postprandial glucose levels may continue to be above recommended levels, requiring the introduction of bolus insulin. Initiating bolus insulin can be tricky. We explored in detail the approach in which Novolog was introduced in a stepwise fashion. It began with an injection at one meal and then added, as necessary, additional injections at subsequent meals. In the stepwise study, the approach successfully lowered A1C levels and was associated with a low rate of hypoglycemia. This concludes today's program on how to initiate rapid-acting insulin in the primary care setting. Thank you for joining us.